Hi, everyone. Welcome to our Setup for Success series for Parkinson's, for individuals and caregivers. We are happy to have you join us today. I'm Melissa Mockley. I'm one of the social workers working in neurology and working with our folks in our Parkinson's community. These presentations, again, from the University of Utah, but they are made possible in part with the partnership we have with the Parkinson's Foundation. And so I obviously want to highlight that as I begin as well. And let's dive in. So today our objectives are: we want to understand what psychosis is. We want to recognize common symptoms. We want to learn what may trigger or worsen symptoms, explore communication and coping strategies, review treatment and support options, and we want to reduce the shame, fear, and isolation again that often accompanies these types of symptoms. So, what is psychosis in Parkinson's disease? Psychosis can involve when an individual sees things that others do not see, hearing or sensing things that others do not. It might be false beliefs or suspicious thoughts. It might be confusion between what is real and not real. How common is it? Well, up to 50% of people with Parkinson's may experience symptoms over time. Symptoms often develop gradually. Mild symptoms are more common than severe. It doesn't mean you can't have severe, it just means mild are more common. And many people hide symptoms or try to hide symptoms due to feelings of embarrassment or fear. Why does psychosis happen? Well, psychosis might be related to, there's different reasons, but it can happen because of the changes that the brain is experiencing as part of Parkinson's, as part of the progression of the disease. It can happen and be related to the medications that you take for Parkinson's. It can happen from sleep disruption. It can happen because of cognitive impairment or dementia that can accompany Parkinson's disease as it progresses. It can happen from infection or illness that's separate from Parkinson's, but exacerbates Parkinson's. It can happen in hospitalization. Many times we see individuals experience these symptoms when they're hospitalized. It can come from vision impairment, not only neurological changes with vision, but also just our vision changes that maybe we're not optimizing, uh, maybe glasses or corrective lenses that might help us. So vision impairment. And then stress or overstimulation can also cause issues with psychosis. Let's talk a little bit about hallucinations. These are ones that we hear maybe most about, or individuals experience most often. But a hallucination is sensing something that is actually not present. And visual hallucinations are our most common form. So people might see other people, they might see children, they might see animals, they might see shadows or movement in shadows or movement in general of objects. They might feel a presence nearby. You can also hear. There's also auditory hallucinations. So you might hear voices or sounds that other people don't hear. Often these hallucinations occur in evenings, maybe if there's dim lighting, maybe more at night. And again, they often begin mildly. What I don't have included on here are there can also be hallucinations with smell, olfactory uh, hallucinations. Sorry, in my head, I was thinking, did I say that word right just now? Olfactory. I believe I did. Anyway, when we smell things that other people don't smell, that's also something that you can experience. But I don't have it included here because many people with Parkinson's they lose their sense of smell. So it's not always one of the top things. But anyway, just as a side note, it could be something. Going back to the visual hallucinations, examples might be that an individual might say that they see cats running across the floor. They might see children in the house, or they might say something like, I thought someone was standing in the hallway. Early on, many people they realize that what they're seeing isn't real, but it looks very real and feels very real. So sometimes there's awareness and insight into what they're experiencing versus what reality is. Delusions. Delusions are also a part of psychosis. So delusions are different from hallucinations. Delusions are a false, fixed belief that can often bring strong emotions. So they're not based in reality, but they're based in the person who's experiencing them. They're based in their reality, right? Which is different maybe from others. So some examples of what you can see is that maybe an individual believes that their spouse is cheating on them. Maybe the individual thinks someone is stealing from them. They might believe that there are strangers in the home. They might think that the events they see on TV are actually real and are actually part of their reality. Again, delusions feel very real and they're often emotionally intense for the individual experiencing them. Oh, that's not what I meant to do. Let's go back. So illusions and misrepresentations. So sometimes the brain misinterprets reality. It might see something and misinterpret it as something else. So an example of that might be maybe a coat sitting on a chair looks like a person. Maybe a wallpaper pattern seems to move. Or again, maybe shadows might appear threatening. I like this image here of the vase or the two faces facing each other, right? You can see different things here. So if we're having changes in our vision, plus our brain is not interpreting what it's seeing, these changes can cause difficulty for people. It can cause these types of hallucinations or these types of misinterpretations, sorry. Risk factors for psychosis. So longer duration in Parkinson's disease. So as time goes on and the more it progresses and you have this longer space within the disease, that can be a risk factor. Again, cognitive impairment or dementia associated with Parkinson's. Sleep disorders. Age, so older age can sometimes be a risk factor. Vision problems, again, medical illness or infection, medication changes, and social isolation. So if an individual is isolated, that can also be a risk factor for some of these symptoms. As we touched on, Parkinson's medications can actually contribute to psychosis. So some medications that increase dopamine may actually worsen hallucinations. Um, Medication changes can also affect psychosis symptoms. But I want to reiterate, do not stop taking Parkinson's medications. Don't do anything like that on your own, but any kind of adjustments in medications should always be guided with your neurologist, with your healthcare provider, so that they can explore the best options for you and make those recommendations based on what you're experiencing in a partnership there with your provider. When symptoms suddenly get worse, so if you notice a sudden increase or a rapid worsening of psychosis or of these types of symptoms, it might not be related to Parkinson's itself. It might be related to another medical condition, such as a UTI, a urinary tract infection, dehydration. Again, hospital stays can cause a delirium. Maybe it's not necessarily the medications for Parkinson's. Maybe it's medication interactions of just maybe something else or in addition to the Parkinson's medication. So there might be an adverse reaction going on. Sleep, if there's sleep deprivation, and then any other type of acute illness that can also exacerbate or magnify the symptoms of psychosis. And so you'd want to get all of these things checked out or discussed with the provider about any of these things so that we can address it, maybe with antibiotics, or maybe we need to get you know, increased water, obviously, to increased hydration, things like that. I wanted to just touch on, if you're a caregiver, of course, what your person with Parkinson's might be experiencing. And if you're a person with Parkinson's, maybe and you've experienced psychosis, maybe some of these emotions are ones that you can relate to. So many times our individuals feel fear. They might feel embarrassment. They might feel shame, anxiety. They might isolate themselves or feel isolated because other people might start to draw away from them or pull away from them. There might be a loss of confidence or a fear of losing independence or a fear of abandonment that maybe other people might leave if I express what I'm experiencing or if I'm just experiencing these symptoms and it causes all these emotions. For our care partners, our caregivers, they have their own emotional responses that they're too trying to navigate. They might feel alone in this. They might feel the need to be hypervigilant. They might be angry, maybe heartbroken or exhausted, or maybe frightened by what the person is experiencing and confused. They don't maybe understand that this is part of Parkinson's, or maybe confused and how do I respond? What do I do? I don't know how to make things better. So there can be a lot of not only the symptoms, but our reaction to the symptoms matters as well. That those emotional reactions matter. As a care partner, as a caregiver, what can you do? I want to, focus on some of those strategies. And what you say and how you say it matters. So as a care partner, we want to try to stay calm. Our own body language, have that, just a calm mannerisms. We want to try to validate the emotions of what someone is experiencing because the emotions are very real. We want to reduce arguing or correcting. We want to offer reassurance. We want to redirect gently. And then we want to focus on also focus on safety. An example that you might say is, I can see that this felt frightening. That's an example. And we're going to go into this a little bit more in depth here in a moment, but in general, this is a good rule of thumb in how to respond. You want to pause, have your own body, check in with yourself if possible, make sure your own body language is calm. You want to validate, avoid arguing, offer reassurance, redirect if possible, and then of course focus on safety. I also want to go over what usually does not help. But I want to point out this image first. I really liked this image that I found. Can you see how the person on the left sees the number 66? And from their perspective, it is the number 66. And on the right, that person else is also seeing the number 99. Well, that's because from their perspective, it is 99. When someone is in a state of experiencing psychosis, this is their reality. And the more you can join them in their reality, even though it's not yours in that moment, and try to help be a partner with them, try to help provide support and reassurance, then you'll be able to help them hopefully increase the possibility of them being able themselves to respond better and to resolve that episode in that moment versus escalating it. So I often tell care partners to join someone in there, to join the person experiencing the psychosis, try to join them by those last techniques we just talked about and not argue or correct. So these are some of the things we try to avoid. We try to avoid saying, that's not real. If they see cats running across the floor, if they see children out the window, we don't want to tell them that that's not real. We don't want to tell them that they're imagining things. I don't see those cats. You're imagining this. That typically does not help. We don't want to argue or debate. We don't want to, again, we're trying to join them in their reality versus trying to reorient them to ours, which is not where they're at right now. We want to avoid trying to force logic or, again, our perspective on them. And also, we want to try in ourselves to not show frustration. And we also want to not ridicule anyone for what they're experiencing. This is from Parkinson's. This is not something that they're intentionally doing. This is not something that they're trying to cause anyone any difficulty or any struggle. The person in this moment is having a struggle, and we're trying to, again, pause and come into that space calm and seeing what we can do to help. Some validating and reassuring statements that you could make. I'm here with you. You're safe. That sounds upsetting. Let's look together. I'll help you. So this is together type language. Their version of reality, their symptoms, right? If they're seeing cats running across the room, you're joining them. Let's look together. I'm here with you, right? These are things that we're joining them. It's a together kind of scenario now that you're trying to provide this reassurance in. Redirection can look like some of these options, and it can help because you're trying to shift their attention. But if you try to do any of these things before you validate someone, if you try to do it and not be reassuring, like if you just come in and try to like flip on lights and tell them that they're imagining things and look, there's really not this here, it's not always as helpful. So the order in which you do this matters. We want to, again, validate, reassure, and then try the gentle redirection. And some of the ideas for redirection are you change scenery, you change the environment. Maybe you go from one room to another. Maybe you go outside and go for a walk. These are things that you can do. You can turn on lights. Again, reducing shadows can sometimes help. You can try calming music. You can try to offer a snack or a drink. You can try to change the topic to an enjoyable conversation or an enjoyable topic, or something that's I've even sometimes it's not always about maybe an enjoyable topic, but sometimes it's maybe about something that is just helping to redirect to a different topic, period. So it doesn't have to always be, I guess what I'm trying to say is enjoyable, but just something that you can try to shift it to a different topic. Going for a walk, I mentioned that. Sometimes having a family member or a friend maybe call at that time. Sometimes another person being part of it can help to regulate the emotions, can help to actually even reorient someone back to reality, so to speak. So these are things that you can try. I don't know if you've ever heard of Teepa Snow. She's the individual here on your screen on the right. She is an occupational therapist and she's a dementia expert. And I thought I would include, she has her whole a whole program called I think it's called Positive Approaches. Um, and she has lots of videos on YouTube and she has her own website and she has lots of good things. I wanted to include a video from Teepa today. It's about 5 or 6 minutes where she gives an example. She's our case example today. Her and her partner here, Carolyn, they're going to demonstrate for us responding to hallucinations. You'll hear them say in the video, talking about dementia, talking about Lewy body dementia. But in general, we're talking about hallucinations. And of course, we're talking about Parkinson's in this forum today, and what her approach is applicable to all of those different conditions. So I'm hoping that this is going to play okay. But if we do have any issues with audio, Sydney, will you let me know? Will you speak up and say you can't hear or whatnot? But I'm hoping it'll just play and we'll be just fine.
Hallucinations. Seeing, hearing, feeling, smelling, tasting something that isn't really there, but the person believes that it is. It can create an emergency situation or a dangerous situation. Let's see what happens. And at first, there's going to be a reaction on my part and Carolyn's part. And then I'm going to break it down and we're going to demonstrate what can change with a building of skill so that I respond and don't react. After you've done it once or twice, your brain may go, oh, this is starting to feel familiar. That's when you're going to be ready for the pause and the be able to respond kind of thing. Let's try it out. Let's see what happens. God. Oh no. Oh no. Oh no. Oh no. I gotta get it. I gotta get it. I gotta get Carolyn, it. What are you doing? Carolyn, no, stop. You're gonna fall. Carolyn. Jeez. Oh, jeez. I'm gonna pause now. Wow. That went sideways. So Carolyn, did it feel like I was there to help you?
Not at all. Not at all.
Did it feel like I was trying to keep you safe?
It felt like you were trying to physically make me stop doing that thing I needed to do.
Okay. So what did you want to do to me?
I wanted to get rid of you. I wanted to hurt you so that I could get that spider up there.
So you saw me as part of the problem, not part of the solution.
Yeah.
And I saw her as doing something dangerous that I was trying to prevent. Unfortunately, all it did was escalate and make it more dangerous, frankly, for both of us. So what we're going to do this time is I'm going to come in, I'm going to pause myself, and I'm going to acknowledge what Carolyn is doing, not try to stop her from doing it. Let's see what happens when I change what I do. Oh boy. Oh no. Oh, I gotta get it. There's something up there. You got it, Carolyn. Hey, Carolyn, it's a spider.
Yeah, and
oh my God, it's a spider. Carolyn,
it's gonna
get
get
Carolyn.
Yeah.
Carolyn.
What?
Here, give me your hand. Let's get a broom so you don't have to touch it.
All right, let's go.
Here, get down. Here, come on down here. There you go. Good.
Okay.
You did it.
Yeah.
Good.
Yeah.
We're gonna go get the broom. Let's go. Was that a little better?
Much better.
Felt a little better. Now, that doesn't mean that I feel like I've got it all under control. But what I was able to do when I hit the wall, when I said, Carolyn, it's a spider. I used the word she used. I used the energy she used. It became something we were both dealing with. Now, I didn't see a spider. I did see a piece of dirt up there, but me pointing out it was dirt, not a spider, didn't feel like that was going to be helpful. Because what did you see?
I saw a spider.
Whether it's due to Lewy body dementia, advancing Alzheimer's dementia, or whether it's due to a urinary tract infection or something else, in that moment, that's not what's important. Helping Carolyn feel like I'm there to support and help her is what's important. So what I did is I got her down. Now, did she bounce on the bed? Yeah. Was it perfect? No. Did I stabilize her when she came down?
Yeah.
And are we going to find something in another space, a prop in a place that I'm the right person?
Well, you felt like my partner in that versus stopping me from doing the thing that I thought was going to harm me.
There's that thing up there.
Right.
Now, here's the thing. When we get out of here, if she forgets about the spider, who else has to forget about the spider? If, however, she's still worried about it, we go get the broom and we come back. I'm going to brush something off. If it takes care of the spider, for her, took care of the dirt too. We're dealing with hallucinations. We have to appreciate her perspective and mine are different. My goal, support her where she is till I get her to a safer place.
Good.
All right. Well, hopefully you all got something from that. I thought she did a good job in portraying a very, realistic possible scenario there and how to respond to that. Again, she used language that Carolyn was using, spider, gotta get that. She joined her in that. It was a together thing. She went through all of that at the end. I thought that was just a good example that I wanted to share with you. In addition to that video, just if there are known triggers at home or there's things that you could be triggers, we want to try to reduce those. So lighting, if that's an issue, we want to reduce clutter in the home if possible, minimize shadows, maintaining routines can be helpful, improving sleep. If sleep is an issue, we want to do what we can to improve that, and reducing overstimulation. These are some things that can often be part of a solution and help improve the response. As I touched on, sleep matters. It can worsen hallucinations, confusion, anxiety, delusions. I can't remember. I've done a few presentations on sleep. I can't remember if I've done them in this format or not in our Set Up for Success seminars, but we know that sleep is a big concern if you're experiencing Parkinson's, and something that might, obviously be a struggle. So we want to do all that we can to promote sleep, like I touched on. And what I didn't, I don't have it listed here, but of course your daytime activity matters. How active you are during the day can affect your nighttime sleep. You want to, temperature of the room matters. Decreasing your screen time before you go to bed matters. But if there's things that you can do, maybe it's taking a moment for meditation before you go to bed at night. But all those things that can be helpful for sleep hygiene, I would encourage you to do. And if you still have issues, then I would talk to the providers about maybe some sleep aids or something that could also maybe be part of the toolbox. But we want you to do all that you can to promote good sleep. When to contact the doctor, the neurologist, or your medical team. So again, if symptoms suddenly worsen, if safety becomes a concern, if hallucinations become distressing, and I want to pause on this one for a moment. Sometimes our individuals experiencing the hallucinations, they're not in distress about it. Okay, so I saw cats running across the floor. No, maybe it's just matter of fact for me. Or maybe I see children outside playing and it's just matter of fact. It's no big deal. That's not a time to contact the doctor and get medication on board. We're not trying to add more medication when there's already so many chemistry changes going on in the brain. We're not trying to add more medications or things that might, have adverse reactions or just be something else to try to navigate. So if the person experiencing the hallucination is not in distress, but the caregiver is, well, I gently say it's the caregiver that needs to adapt. However, if the person experiencing the hallucination is in distress, it's a time to talk to the doctor. And as I shouldn't say it's the time, but as a caregiver, if you're not able to help with that distress or to help provide relief, then it's definitely a time to maybe consider contacting the doctor, right? Because that's a time to have an additional intervention with this. Delusions can create conflict and fear. Again, the delusions are those fixed false beliefs that, maybe someone is stealing from me. And there are, just as we talked about, there are some communication strategies that can be helpful. But if they're causing distress for our individuals and you're not able to try to help, if what you're doing isn't helping to try to alleviate that, then maybe it's time for an additional conversation with the doctor. If sleep significantly worsens, it's not getting better, you're doing what you can and it's worsening, time to talk to the doctor. And as a care partner, as a caregiver, if you're noticing in yourself that you're feeling burned out, if you're feeling, there's some burnout warning signs here we're going to go over, but that's also a time to talk to the doctor because what you're currently trying to do, what you're the interventions that you're maybe that you're again trying, if it's not working and you're noticing your own well-being isn't affected, it's time to talk to someone else. When you talk to the doctor, there might be options, of course, that they go over, including medication review. Maybe there's medical causes. We talked about UTIs, maybe an infection. That could be part of that. They're going to talk about sleep, try to help, environmental changes that we've reviewed. They might even talk about counseling or support, different types of, maybe even social work support. In the clinic here at the university, we have counselors, we have social workers that can be part of the team and maybe help either an individual or care partner, in their approach to the psychosis symptoms. And then also there's medications that are specific for psychosis that could be just a valuable conversation to have with your provider about. As we talk about what some of these, again, knowing what these psychosis symptoms, what can happen. Of course, if you're an individual with Parkinson's, you already have a fall risk, right? And adding psychosis into that can increase the risks for fall. Maybe if you're trying to step around an animal that isn't really there, or if you're trying to reach for an object, just like in that video, that individual reaching for a spider that isn't really there, right? Increases the fall risk. The wandering risk can increase because if you have a delusion that there's people in your home and you feel unsafe, you might try to leave the home um, to go out and in the neighborhood or something like that. It increased the wandering risk. Firearms, obviously a concern if you're feeling unsafe and you might think that you need to protect yourself. Or driving concerns. Maybe if you're having a hallucination and you feel like you need to drive away from something or towards someone else, that's a concern. Nighttime supervision, again, many of these things can increase or can happen at night. And so emergency contacts can be helpful, but we want to try to do what we can in the home to reduce some of these risks. So there are things specific that you can do for fall risks. Again, removing clutter, wandering. Maybe there's certain types of locks that you might have on the door or an alarm on the door. Of course, removing firearms is something I highly recommend. Driving, you might remove access to someone's vehicle if that would be helpful. Maybe you increase supervision at night. Sometimes people will use, again, notifications or alarms or apps or things to try to increase monitoring for individuals. So there are things that we can try to do to be proactive also as we're trying to navigate some of these concerns. As I spoke earlier about caregivers, right? Our caregivers need support too. They need care too. And some of the signs for yourself of burnout can look like chronic exhaustion, irritability, depression, isolation, feeling trapped, and your own health declining. These are warning signs that maybe what you're currently trying to do or your current system needs more help, and time to maybe reach out to others to see what support is available. Some of those support resources could be a Parkinson support group, could be an individual counselor. It could be respite. Maybe that is you just need to have time off the clock and time away from, being a caregiver. And so maybe it's time to talk with others about how to get that respite or to, whether it's a friend or whether it's a professional or community resource, knowing what options are available could be helpful. Social work support not only in a counseling type environment, but even meeting with someone like myself. We talk about some of these, specific concerns. We offer strategies specific to your scenario, your circumstances. That could be helpful, obviously. Home health services, whether that's having occupational therapy, physical therapy coming into the home, that might offer some, again, strategies, therapies, things that can help with, of course, balance, but even an occupational therapist can look through the home and see if there are supports that could be instituted that could help a person navigate their space better, and maybe even look at lighting or things like that that might help reduce some of these hallucinations or things like that. Personal care agencies. So again, one of the risk factors for psychosis is isolation. So you might even have and maybe additional caregivers come in from a personal care agency to reduce isolation, to have more connection with people. And that can also be just we're helping somebody to stay active. We're helping someone, maybe we're promoting sleep. So there's all sorts of things that additional caregivers can come in and provide if that's a feasible option. Education is available for our care partners through the Parkinson's Foundation. Sydney can connect us to a lot. She offers many, education opportunities, and she's aware of that and can connect. Um, I'm one of those resources. We can meet to talk about educational topics too. And then just in the community, what supports and things are available there. We can review that, and Sydney can also help connect you to that. So there are resources, not only for our individuals experiencing Parkinson's, but for our care partners. Key takeaways I hope you receive today or will walk away with is that psychosis in Parkinson's is common. Again, up to 50% will experience this, and from mild on down the line to severe. Symptoms are neurological. They're not intentional. No one wants to be experiencing these, right? No one's trying to cause anyone else a hard time. They're having a hard time. Validation from our care partners works better than arguing. Sleep and illness and stress sleep and illness can stress things and make them worse. And that also there is support. There's support for both our patients and our care partners. Just want to reiterate that we don't have to navigate this alone, that there are supports and resources available, and we are set up for success is just one small sliver of support, these seminars, but we're trying to reduce stigma. We're trying to increase connection, and we want you to know that there's help available, and we're part of that.